again, good afternoon, everyone. I'm thrilled and honored to be here, and thank you to Dean Ratliff-Crane and to Augustana for inviting me, and thank you to Dara for that kind and poignant introduction. The 4 years I spent here really formed a foundation for how I would later approach my profession, and it must have been so memorable that the other day I was rifling through my things and I actually came across this. So, yes, that is my senior year student ID. Hopefully digital technology has gotten much, much better since those days. And all I can say is I must have really wanted to commemorate my experience here at Augie, either that or I just don't ever throw anything away. All of their embarrassing photos aside, when I was first approached to speak about my career path here, after graduation and subsequently how I have used my degrees, I will have to admit that I had more than one moment of complete mental void. Having to incrementally examine the last 12 years of your life can be very overwhelming, because on one hand it passes in one swift and sudden blur, with you actually having conscious control over a frighteningly small proportion of it. But on the other hand, having to dissect time spent makes you keenly aware of how many important life events and moments have to have occurred for you to be where you are today. So I wanted to illustrate my presentation today using examples from one of my favorite books by Dr. Seuss, because he is so able to truthfully depict life and the obstacles that we have to overcome, and he does it in perfect syncopated rhyme. So he states, "You have brains in your head, you have feet in your shoes, you can steer yourself in any direction you choose." Putting it simply and in context here, you already have and are further developing the skill set that you will need out in the professional world. You may just need a little bit of help finding which direction you want to take it. So not to worry, you've already made the excellent choice of coming here to Augustana, where you are valued as an individual, and if you so choose, there are people who will personally invest themselves in your success. I'm sure that many of you are familiar with this graphic. I can tell you that at one time in my life, I really did think my career path would look like the illustration on the left. I thought that all I needed to do was get good grades, diversify my social and volunteer activities, and anything that would look good on a transcript. And then I'd graduate, I'd go to medical school, residency, then I'd live out my remaining days at a thriving and fulfilling academic practice. It's sort of a happily ever after, so to speak, and much easier imagined than done. So what college doesn't prepare you for very often, which is why I'm so glad that Augustana puts on career symposiums such as this, is that linear lines don't often occur in nature. So what actions do you take when you have to go off course? Well, you'll have to extrapolate or create your own lines from what is given. So it doesn't necessarily look like the depiction on the right, but more like this. So you'll have to forgive me, I love data and data sets, so I will reference them anytime to anyone. Let's pretend for a moment that far into the future, you'll be able to retrospectively look at your own career milestones. I believe that they would look somewhat similar to this linear regression, with the data points forming a picturesque mountain range with a path cut through for passage. I actually urge you to take the non-linear career path. It's much more scenic and it's much more fun. I tried to map out my own career path, but as an example, but since I don't have as many career points as this graph, I instead used simple graphics. So it all started here in the safe Augie bubble. Like many of the students here, I was a pre-med major, and I called the science building my home for 4 years. But through the advising program and Augustana connections in the community, I was able to experience other professional paths in health surveillance, social and volunteer work, and pharmacy. When I ultimately decided not to go to medical school, it was actually Professor Wegman-Geedy who talked to me about this back then new program in public health, because it might open more options than the traditional path in medicine. And lo and behold, it did. Grad school introduced me to career possibilities in biostatistics, research, public and health policy, and the list goes on and on. These fields are working in tandem and symbiotically with medicine, though not actually in practice of it. It was definitely eye-opening. but I still didn't really know what to do with this information. At some point, you just have to take a chance, or you're sort of forced to jump into it. After grad school, I worked for a while in different academic medical schools and in the private sector, working in research regulation, learning about the laws governing the FDA and medical device approval, and the foundation of and the code of conduct for animal and human subjects research, and also institutional research compliance. This is all just a way of saying that what I didn't know about myself prior, but I did learn about myself after, is that I really, really like following rules. So naturally, I decided to go to law school. Honestly, I can't tell you very much about those 4 years, except that it wasn't anything like Harper Lee described. What I can take away from it, for any of those who decide to go to school full-time and go to, or work full-time and go to school part-time, it's doable, but it will take its tolls, especially if you decide to, in addition to everything else going on, get married in the middle of law school. I felt very privileged to have close friends and family who loved and supported me, because I really needed to rely on them to get me through it all. And however, they might have actually liked me a little less afterwards. I sometimes get approached by people seeking advice about going to law school or getting a doctorate, or thinking that they want to go into like clinical or basic science profession. And I always tell them the best time to make those difficult decisions about your career is before you choose to commit 3 to 7 years to being in school. Because ultimately, you have to graduate. You may or may not decide to use that degree, but you still have to subsist. And student loans won't really make it any easier to do so. So I usually urge students to take on internships or shadow people already in the profession, or just to get a better, more realistic sense of the job. Or you can volunteer, serve on different community boards and get experience. I don't think you'll ever regret donating your time to a cause. Moving forward in my own timeline, while I was in school, I continued to work at a dual appointment at Baylor College of Medicine and Texas Children's Hospital, doing pediatric neurosurgical research. And I was given a faculty appointment in 2012. I also used my law degree in a very less traditional way, managing the administration of research through a nonprofit that is directly aligned with clinical and basic science practice in the veteran population. So this is where I am now, but that is just one career path I can continue on. I hope for myself, as I do for you, to explore lots of career possibilities and opportunities in the future. But as I've now spent close to a decade researching pediatric neurosurgical disease and outcomes, I would like to speak to some of those medically significant issues that affect millions of children worldwide, of which researchers like myself are trying to improve health outcomes, as well as investigate the underlying cause in order to find both feasible treatments and a cure. The disease process that is my main research focus is called hydrocephalus, coming from the Greek stems of hydro for water and cephalus for head. Anatomically, as humans, we have a set of 4 interconnected cavities in the brain that continue through the central cord and central canal and to the spinal cord. These cavities are called ventricles, and they are where the cerebral spinal fluid is produced. Hydrocephalus is a process in which the rate of CSF is absorbed by surrounding villi and ultimately into the venous system. That rate is off balance, and instead it builds up within the ventricles of the brain. This normally causes the intracranial pressure, or ICP, to increase, which in early signs will cause headache, vomiting, lethargy, or even coma. And it becomes life-threatening in that the severe ICP can cause cerebellar or tonsillar herniation, also brainstem compression and death. In children whose cranial sutures have not fused, the internal pressure causes the head to grow and grow. So left uncontrolled, their spine and neck will be unable to support the weight of their head, and they're often left physically immobilized. Congenital causes that we know in children causes an increase in the likelihood of hydrocephalus are spina bifida, Chiari malformation, craniosynostosis, and Dandy-Walker syndrome. Hydrocephalus is also an acquired condition caused by intraventricular and intracerebral hemorrhage, meningitis, traumatic brain injury, brain tumors, and cyst development. But there's a smaller but significant proportion of cases where the etiology of hydrocephalus is just unknown. Hydrocephalus is diagnosed in 1 to 2 of every 1,000 babies born, but because it is not just a congenital condition, older children and adults are also affected. Over 1 million children and adults in the US are living with hydrocephalus, and these are just the cases that are having ongoing treatment. And over half of all brain surgeries in children done in this country are due to hydrocephalus. Currently, there's no medical management for the condition. There's only surgical treatment. That being said, hydrocephalus can only be diagnosed clinically. As you see in the illustration on the left, in the hydrocephalic brain, the ventricles are usually enlarged. This is not always the case. And even if they are enlarged, the patient may not exhibit symptoms. It is not until there are both clinical signs and symptoms and radiographic evidence of enlarged ventricles that hydrocephalus is diagnosed. The most prevalent surgical treatment of hydrocephalus is called a ventriculoperitoneal shunt. A catheter is attached to a valve that is either pressure or flow regulated, and it is surgically inserted into the ventricle. The system is then connected to a flexible tubing that is tunneled through the neck into another region of the body, sometimes the heart, the gallbladder, the lungs, but most often the abdominal cavity. There, the CSF can be absorbed, and this normalizes intracranial pressure. Patients normally feel immediate relief after shunt placement. It sounds incredulous, but usually we discharge patients the day after they have brain surgery. The second treatment for hydrocephalus that has become more widely accepted as standard practice is called the endoscopic third ventriculostomy, with or without choroid plexus cauterization, or ETV and ETV-CPC for short. In this procedure, a rigid or flexible endoscope is used to puncture the membrane on the lower third ventricle through the hypothalamus to allow a pathway for CSF to flow. In infants who have a choroid plexus, where the CSF is produced, the choroid plexus is cauterized or burned by a bug bee in order to reduce the rate of CSF production. ETVs have gained much more popularity because there's no existing hardware that's left in place in surgery, and that is really important in developing countries where access to a hospital, and especially a hospital with higher level of care and neurosurgeons, is very rare. But ETVs have a historically high failure rate, ranging anywhere from 20 to 80%, depending on age and condition. So after an ETV is failed, a shunt is usually placed. However, shunt failure rates are not that much better. Previous randomized controlled trials of shunts have demonstrated that there's a 40% failure rate in the first year, a 50% failure rate in the second year, and then a 5% chance of failure every year afterwards. Many of the children we see at Texas Children's Hospital have multiple brain surgeries in a year. It is really not unusual to see a child who has had 10 to 20 plus surgeries before his or her 18th birthday. The most common reason for shunt failure is that it becomes obstructed with blood products or cells in the brain or abdomen, but shunts can also become fractured or dislodged, and this requires a neurosurgical revision, either fixing a component of the shunt or replacing the entire shunt entirely. Symptoms of shunt malfunctions are also not completely apparent. Sometimes they show up as flu-like symptoms. And especially in babies who can't complain of headaches, it is important to have ancillary radiographic imaging. Not diagnosing a shunt malfunction in time can lead to catastrophic outcomes. Another cause of shunt malfunction that is clinically significant is the shunt infection, which is, according to the shunt design trial, is approximately 8% in the first year. The shunt is a foreign device in the body, and it can be infected by different organisms. The most common being Staph epidermidis. Staph aureus is also diagnosed as a secondary cause of infection. And both gram-positive cocci are normally found as skin flora. They are part of a bacteria that are quickly acquiring antibiotic resistance and are difficult to treat, even in a hospital setting. Shunt infections can also secondarily stem from an infection in the abdomen that contaminates the shunt, and vice versa. Shunts that are placed in the atrium or in the heart may cause a systemic blood infection, which quickly becomes very serious and may lead to sepsis. Another very important research study also provided convincing data that shunt infections, much like congenital hydrocephalus, is highly correlated with a significant decrease in IQ and cognitive function. A shunt infection also leads to a 10 to 14-day additional hospital stay while the patient is treated with antibiotics. Research in a particular condition or disease typically arises because there is a real need for that research. And it was very clear that something needed to be done on a larger scale for pediatric hydrocephalus. So in early 2007, originally 4 children's hospitals with large academic medical centers and research support came together to form the Hydrocephalus Clinical Research Network. And over the years has expanded to 9 centers, including 2 in Canada. Clinical research is very much driven by the number of patients that are eligible to be enrolled in ongoing studies. By developing and standardizing research protocols across North America at large hospitals, the network is able to obtain sufficient sample sizes to power studies and to study this condition in a very diverse population. The network goal is to guide medical practice using evidence-based research to improve the diagnosis, the treatment and outcome for hydrocephalus patients, and ultimately improve their quality of life. I am very honored to have been part of the initial process in forming this network, and I'm very proud of where it has come since then. Presently, every center in the network is concurrently running these trials that we believe to be crucial in understanding hydrocephalus. The network has created the first ever registry of pediatric hydrocephalus patients, and over 400 data points reflect on each patient. So over 8 years, we have almost 10,000 patients enrolled. And having real-time data really allows us to quickly collect and test hypotheses and generate future studies when a need is identified. Using a standardized and quality improvement technique, we have helped to decrease the shunt infection rate in the operating room and afterwards by 2 to 3%. I'll speak to this study later on in the presentation as we have modeled another protocol on this one because we have seen so much success. There is a randomized controlled trial of anterior versus posterior shunt placement with the objective of determining whether one surgical approach results in longer shunt survival. This trial will prospectively follow infant patients who receive an ETD CPC and review both their neuropsychological but also clinical outcomes. And we'll compare these patients' IQs to similarly aged children over a span of time, usually 5 to 10 years. We have another study solely looking at neuropsychological outcomes of infants who have congenital post-hemorrhagic hydrocephalus. We currently have one basic science study that looks at the neurodevelopment biomarkers, specifically the protein coding gene L1CAM. And we look for elevations in these biomarkers in babies born with intraventricular hemorrhage compared to those who are not. And finally, there is also a trial reviewing 2 different temporization techniques used before a permanent shunt is placed in premature children who have intraventricular hemorrhage. In addition to research in hydrocephalus, I also spent a large proportion of time working on quality improvement processes in the hospital setting. These are projects that include standardizing a certain process in order to produce better outcomes. One thing that you'll learn, or you'll quickly learn as you advance in your career, is that you really try never to reinvent anything and you recycle whenever you can. To give you a prime example of this, I already gave this speech at a surgical quality improvement process symposium last year. So I sort of cheated a little bit. It's a multi-year project that we've undertaken at Texas Children's Hospital to reduce spinal device infections. And we've done so in partnership with Hospital Spine Group, which is a collaborative group of neurosurgery and orthopedic surgery, dedicated to studying the conditions and outcomes of pediatric spine disorders. Surgical site infections after pediatric spine fusion are pervasive in the scientific literature, with rates ranging from the percentages you see here. Surgical site infections have a tremendous impact and burden on patients and families, as well as in part a significant cost to the healthcare system. Considerable variation exists in infection prevention practices by both center and surgeon, most likely from differences in training and expertise, as well as gaps in available evidence about potential practices. We have seen in both recent work that both medicine and surgery have benefited from quality improvement methodology, which involves development and the execution of standardized incremental protocols to decrease any unexplained clinical variation. It also includes the measurement of compliance and the observation of the effect on that outcome. For example, the Hydrocephalus Clinical Research Network that I mentioned earlier, we used that model to inflect our protocol after, and we demonstrated a decrease in cerebrospinal fluid infections from 8.8 to 5.7% while using their protocol. Our goal as a collaborative spine study group was to develop and apply these QI methodologies as well as evidence from literature to develop a standardized multi-step protocol to reduce the 12-week acute infection rate. All spine surgeons agreed to collaborate, which in itself was no easy task. And the protocol was prospectively applied to all spine fusion cases from August 21st, 2012 onward. Acute infections were defined as any positive wound culture within 12 weeks of surgery, and the definition was the same pre-protocol as it was post-implementation. Data regarding prior spine infection rates were provided to us by our hospital infection control department for the previous 5 years, where they ranged from, did the mic go off? Did we miss like 10 slides? Okay. Okay. Data regarding prior spine infection rates were provided to us by our hospital infection control department over the previous 5 years, where they ranged from 3.4% rate of infection to a high of 8.9%, which was consistent to the numbers we see in the literature. Not to ruin the surprise, but since the implementation of the protocol, we have seen an average a 2% infection rate, and the hospital-wide spine surgical infection rates are at a new low of 1.2%. Prior to the protocol, individual surgeons used a variety of perioperative techniques to prevent infection. And the cornerstone of QI is to reduce variation. So the study group used both current literature as well as prior institutional experience to develop a multi-step protocol, which was revised at bi-monthly meetings until a consensus was attained. The protocol was then reviewed by infection control, pharmacy, both neurosurgery and orthopedic operating room staff, and it was approved by the IRB and quality and patient safety. Entry criteria into the protocol were all children who underwent a spine fusion with instrumentation or revision with instrumentation left in place. For data collection, this form was used, and the surgeon or staff in the operating room was responsible for completing the form. Any form that was completed was considered to be compliant for our purposes. And all data were recorded, and compliance with each individual step was noted. Now, at the 36-month protocol period, we have over 670 cases with a 69% rate of forms completed. We recorded compliance with each individual step of the protocol, and even those we deemed as needed or PRN. And these will be used for a later logistic regression to see which steps may be significant in decreasing the rate of infections. This is a graphical depiction of surgeon compliance with the completion of the QI form in the operating room. And we're starting to see a slight upward trend in the rate of compliance, perhaps due to better education and communication with the staff at our hospital. All patients were evaluated for infection at the time of clinical follow-up, emergency room visits, or hospital admission following the surgeon's usual practice. Infection episodes were reported by the month that the initial surgery occurred. After the first year of protocol implementation, our institutional infection rate fell as low as 1.8%, and now at 36 months, the infection rate has remained fairly consistent at 2%, and as low as 1.2% with a few months left still in the calendar year. We also wanted to review infection rates by spine surgeon, and we have coded them for anonymity. Each surgeon performed between 1 and 231 procedures. Surgeon-specific infection rates did not appear to correlate with case volume. However, it is interesting to note that the surgeons who had the lowest rate of QI form completion also appeared to have the highest incidence of infection. And there may be several factors that may influence this, such as complexity of the case and patient diagnosis. Overall, we found that at our institution we saw a significantly lower infection rate post-protocol versus pre-protocol. After the start of the protocol, we were able to go 205 days until the next infection episode. And now, on year 3 of the protocol, we have been able to keep the infection rate low and are currently at 228 days since the last infection, which is the longest time period we have gone since the beginning of the quality improvement implementation. In conclusion, we have found that a standardized protocol for instrumented spine surgery significantly reduced our rate of surgical site infection. The overall compliance rate into the protocol was good, with always room for improvement. We hope that this initiative has established a common baseline at our institution and will facilitate assessment of new treatments in the future. For the next steps of the protocol, we may try to observe surgeons with very low infection rates to determine those factors that may be clearly significant in reducing the number of infections. We would like to further decrease any clinical variation. And currently, we have formed interdisciplinary hospital work groups to advise on subspecialty specific surgical practices. And they will advise us on how to apply the methodology in order to bring the infection rate even further in the future. And of course, this study would not have been possible without the hard work and dedicated focus of many individuals. It seems so simple, but by essentially decreasing the number of operative variables, one can affect the rate of acquired surgical site infection. And not only did we improve health outcomes, but we also improved greatly and significantly. We also improved things like financial measures and decreased the cost of hospital stay and impact and burden on patients and families. And that is really the cornerstone of public health, is just to improve patients' lives. There are, of course, many other research concentrations within pediatric neurosurgery besides those that I have spoken about today. But given that pediatric neurosurgical research is also a smaller field of research than many. However, as you can see here in this graph, it still actually touches upon many disciplines within the vast system of public health. I hope that I've been able to highlight some of the most prevalent problems that this patient population encounters. That as researchers, we are trying to find answers to. I also hope that it has been for you an example of the breadth and the scope of what you can ultimately do with a focus in public health. Especially if you're considering a career that is alternative to the traditional paths in, for example, medicine, dentistry, or pharmacy. I implore you to reach out to the people out in the fields and just talk to them and ask them what they do. I've talked to many other Augustana alumni since I graduated, and we always try to help each other. And I would definitely recommend that you use your current advisors and mentors here while you still have them. I know I will never regret having asked for guidance from them. You're at a time and at a place in your life where the options are endless, and being here at Augie is certainly one of the best choices you've already made. I know that Augustana will always have a special place in my heart, as I hope it will for all of you. I have utmost confidence that you will find your perfect career path one day, and the places you'll go with it. Thank you so much for having me here today.
Protocol and then the rates of compliance by the doctors. How did you measure that, and then also how did you encourage them to use the protocol?
That's a great question. So rates, when you put together a quality improvement protocol, it almost doesn't matter what the steps are. It's just that everyone follows the same steps. And so we called each component compliant when someone completed all the steps on one protocol form. So after the surgeon operated, we fill up the form and say, did we have less than 200 cc's of blood loss? Did we use ANSEF, or did we use IOBAN pre-incision? And so that was noted as compliance. And honestly, in the first year, we had a terrible compliance. Surgeons don't typically want to change a lot of their practices. They have specific training, they have specific education, so it's really hard to change the mindset of a doctor or a surgeon. There's actually health research out there just in the field of changing physician mindset. And so it was a tough task. So we did things like we made it easier for their nurses to implement these protocols. We used operating room staff, better education, incentives for the surgeons. We did things like code surgeons so that they weren't specifically called out for their infection rate, but they still knew who they were, so they had to take ownership of it. And then the second year, after all of those initiatives were implemented, the rate of compliance greatly improved.
Other questions? In terms of your pathway, you were also a sociology major.
I was. I actually was a sociology minor, I believe. I took a lot of Peter Convisto classes. I'm not sure if he's still around. I was really interested in the social aspects of how people think and act and historically where they have come, because I think without a basis and a foundation, we don't know who we are as people. And so I think that's, even though I don't use it in my daily life, I think will never be anything that that I will regret doing or studying while I was here.
It said on your profile that you had some experience in social work. What types of jobs or internships did you have in that field?
A lot of them started here, actually. I worked at the Handicap Development Center. I don't know if some of you are familiar with that. That's over in Davenport. I highly recommend it. It's an integrated program for special needs adults to work out in the real, professional world. So what I would do is I would drive them to job interviews. We would, play games at home, or we would do things that just normal people do without imposing a burden on and focusing on their specific mental or social disability. So I really greatly enjoyed that. I know there's lots of other fields in social work that you can work on, but I especially like working with special needs adults.
Any others? Sheila, thank you so much for coming to this.